In a diffuse supravalvular aortic stenosis extending up to the head vessels, extensive reconstruction of the aorta is necessary. The operation is performed under deep hypothermia and circulatory arrest. The head vessels are dissected and snared or clamped during the period of deep hypothermia and total circulatory arrest. A long incision is made in the ascending aorta, well down into the non-coronary sinus of valsalva and well up into the aortic arch, the transverse portion, and the upper descending thoracic aorta if necessary. A patch of homograft bovine pericardium or Gore-Tex is tailored to appropriate size and shape and sewn with a running suture of polypropylene. Now we will discuss the results. First, aortic valvular stenosis in neonates. Since it is first used in 1986, primary balloon aortic valvotomy for neonatal aortic stenosis has replaced surgical valvotomy at many centers. In a series of 130 neonatal balloon aortic valvotomies, reported 14% early mortality and 15% incidence of significant aortic regurgitation. They identified young age, pre- and post-balloon aortic valvotomy gradient, and large balloon annulus ratio as significant factors predicting future reintervention. Neonatal surgical aortic valvotomy has been reported to have mortality in the range 10 to 40%. Habra and colleagues have suggested that surgical aortic valvotomy has better results when tri-leaflet anatomy can be achieved at valvotomy. Reintervention is common following either procedure, 25 to 40% at 5 years. Aortic valve repair. Some published reports include aortic valvotomy and commissurotomy as aortic valve repair procedures. This at times complicates the evaluation of results of aortic valve repair in general. Hassania et al. Reported 17.6% and 35.2% incidence of mild and moderate aortic regurgitation, respectively, with 47.1% incidence of reoperation on aortic valve during follow-up of 5.3 plus 2.4 years. Tvedal and colleagues reported comparable results of complex aortic valve repair to aortic valve replacement with freedom from reintervention at 1, 5, and 10 years of 94, 85, and 44 compared to 96, 77, 77 respectively for aortic valve replacement. Aortic valve repair has been carried out for aortic regurgitation associated with bicuspid aortic valve. Fraser and Me reported freedom from aortic valve reoperation of 94% and 89% at 12 and 24 months respectively. Aortic valve stenosis in children. Heterograft and homograft aortic valve replacement. Use of heterograft xenograft for aortic valve replacement in children has been discarded following reports of early degeneration, calcification, and structural failure. Homograft replacement of the aortic valve can be achieved with low morbidity and mortality. However, it suffers from the same problems as heterograft and xenograft, but over a long period of time. O'Brien reported 47% freedom from reoperation at 10 years in young patients receiving homograft for aortic valve replacement. Mechanical aortic valve replacement. In children, this carries low morbidity and mortality with a reasonable long-term outcome. Alexio reported 5.3% mortality with survival at 10 and 20 years of 91% and 84% respectively. Freedom from thromboembolism was 93%, freedom from valve-related events 86%, and freedom from reoperation at 20 years 86%. Pulmonary autograft. Pulmonary autograft has been performed with low morbidity and low mortality by many centers. Rask and colleagues reported mortality approaching 0, freedom from reoperation on autograft of 93% at 5 years, and freedom from homograft replacement of the right ventricle outflow tract of 90% at 10 years. Unfortunately, autograft root dilatation is common late after implantation. This may affect nearly 1/3 of patients receiving pulmonary autograft. Freedom from reoperation on autograft of 90 to 95% at 5 years, and 88 to 91% at 7 years has been reported in children. Luciani et al. Younger age at operation, bicuspid aortic valve, geometric mismatch between aortic and pulmonary roots, and the technique of autograft insertion has been suggested as important factors. Homograft dysfunction due to calcification and degeneration is reported in 6 to 20% of patients at 10 years. Factors leading to homograft dysfunction are the use of aortic homograft, use of a small size graft, age less than 10 years, homograft storage times, and possible immune reaction to the homograft. During 1994-2005, 126 patients underwent Ross and Ross-Conner procedure at Great Ormond Street. Median age was 14 years. 80% of patients had undergone previous interventions such as balloon aortic valvotomy, surgical valvotomy, aortic valve repair, aortic valve replacement, resection of subaortic stenosis, Conner procedure, and repair for other congenital heart defects. Patients had undergone previously 2 or more procedures on left ventricular outflow tract. 9 patients had undergone previous aortic valve replacement. 9 patients required Conner or modified Conner procedure with pulmonary autograft for complex left ventricular outflow tract obstruction. There were 4 early deaths and no late deaths. 3 of 4 early deaths were in our early experience. At median follow-up of 28 months, there were 11 reinterventions, 7 were autograft related, aortic root dilatation in 1 patient, infective endocarditis in 5 patients, and cusp perforation in 1 patient. There were 2 homograft related interventions. Subaortic stenosis. Early results of relief of discrete subaortic stenosis are generally satisfactory with a low operative mortality. However, there is significant late morbidity related to residual recurrent left ventricular outflow tract obstruction. Recurrence rates of 7 to 27% and reoperation rates 4 to 35% have been reported. Diffuse subaortic stenosis or tunnel type subaortic obstruction is uncommon. Jahangir and colleagues have suggested that the majority are secondary to other congenital heart defects. A recurrence rate of 14% at 5 years has been reported. Supravalvular aortic stenosis. Early mortality of 1 to 10% has been reported. Long-term outcome depends on the status of aortic valve, subaortic region, and involvement of coronary arteries. Recurrence rates of up to 25% have been reported, with freedom from reoperation of 86% at 10 years and 66% at 20 years. Hazekamp have reported no difference with type of surgical technique, but shows that 3 sinus reconstruction achieves better symmetry and restores normal aortic root anatomy. Rheumatic aortic valve disease. Aortic valve repair has been attempted for rheumatic aortic regurgitation with reasonable success. In patients undergoing aortic valve repair for rheumatic aortic regurgitation, Talvar et al. Reported survival of 95.2% and freedom from reoperation of 85 at follow-up of 160 months. However, freedom from significant aortic stenosis or aortic regurgitation was 52%. Pulmonary autograft has also been used in the treatment of rheumatic aortic valve disease. However, the results of pulmonary autograft in rheumatic aortic valve disease are poor compared to its use with other causes of aortic valve disease at any age. Kumar et al. Have reported freedom from significant aortic stenosis or regurgitation 91% in non-rheumatics and 80% in rheumatics. At median follow-up of 90 months, event-free survival was 86 for non-rheumatics, 68 for rheumatics. They have also shown the rheumatic effect in explanted autografts. They don't recommend pulmonary autograft for younger patients with rheumatic heart disease, opting for aortic valve repair as far as possible in such circumstances. Thank you very much. This was the last mid topic of the surgery of the left ventricular outflow tract obstruction. Thank you very much. Be with us. See you later.